Hello everyone, Bob Sullivan here for part 2 of the trauma overview. And this is going to be, we're going to talk about, briefly cover some of the ALS interventions we can give to trauma patients. We'll get into more detail later as we go into the different conditions. But if you take one thing away from this is if there's an insult that we don't manage in the primary survey or that we don't identify in our rapid trauma exam, so needle decompression, airway management, assisted ventilation, pelvic binder, bleeding control, all of those things that are immediate life threats that we need to manage or at least start to manage before moving, then the other interventions can wait and should be done on the way to the hospital or while waiting for the helicopter, because our goal is to get to the trauma center, the closest appropriate trauma center, depending on where we are, as quickly as possible, because that's where definitive care is. And any time that we spend doing interventions that aren't definitive or aren't going to definitively treat the patient's problem, we're stealing time away from the surgeon. So what interventions are we going to do? Well, first of all, the vital signs, the cardiac monitor. After we've done our rapid trauma assessment, we should, if we identify a critical patient or a patient that meets the trauma center criteria, we should do those on the way to the hospital in the ambulance. So we finish our rapid trauma assessment, we package the patient, maybe with spinal precautions, and we move them to the ambulance. And as soon as the back doors of the ambulance close, the wheels should start moving, and we can finish the rest of our assessment there. If you see a patient with, laying on the ground, who's struck by a vehicle, and you pull up in the Suburban and you walk by the ambulance, you can put your equipment you can put your heart monitor into the Suburban or into the ambulance. Because the patient will most likely get hooked needed in the ambulance, and you can just help move him to the ambulance faster. So, this is a different approach to medical patients. With medical patients, there are more conditions that we have a specific treatment for that we can fix or at least start to manage. With trauma, we want to do this on the way to the hospital. So we're going to do our vital signs. We're going to get our history in the ambulance, hook the patient up to the cardiac monitor, pulse ox, end tidal, check a blood sugar if we can. And one of the interventions that we have is IVs. And we see patients come into the hospital with IVs started. And IV fluid can be harmful. The PHTLS recommends lactated ringers. In Delaware, we carry normal saline. IV fluid increases cardiac output. It increases preload in patients who are hypovolemic, but it does not carry oxygen, and it can make clotting. It makes clotting worse, and it can actually worsen acidosis. So PHTLS recommends a systolic blood pressure of 90 is our goal for fluid resuscitation. That's controversial. Some people think it should be lower. That's what we're going with. And the reason they picked 90 is because hypotension in head injuries is bad. So we want to give enough fluid to perfuse the brain, but not as much as to dilute the clotting and dilute the blood more than we have to. A more recent intervention that we have available to us is tranexamic acid, or TXA, which can be now given as a slow bolus, which will improve clotting. This could be good. This can be good. The bleeding must have started within the last hour. So if we don't know how long the patient's been bleeding for, we should withhold it. If we know that the bleeding began an hour ago, we can give it. Still not worth staying on scene to give. This is something that can be given in the ambulance or in the hospital. And something that's coming that's new is ambulances, ground ambulances carrying whole blood, which also this could also be life-saving. This will buy time to get the patient to the trauma center. Anything that we give by IV, by the way, should also be warmed. They make fluid warmers. Like we talked in the last recording about the trauma triad of death. So we want to give warm IV fluid. If we give room temperature IV fluid, that would could make the patient cold and actually more hypothermic. But anyway, so something else that is exciting is whole blood, which you may be seeing in Delaware soon in some services. So another treatment that is available to paramedics is the advanced airways. So intubation, and supraglottic airways, and then after that we have drug-facilitated intubation, where we can take a head-injured patient and give them drugs to paralyze them and secure their airway with an ET tube. And we'll get into more detail with this we do head injuries. But one thing to think about is if the patient has any kind of airway compromise at all, or their teeth are clenched, and so we will not be able to place an advanced airway or any ET tube or supraglottic airway past their clenched teeth. If they vomit, they'll aspirate, and we may not be able to oxygenate them then. And we can't generally don't want to put them on a helicopter. I wouldn't say never, but you generally would not want to put them on a helicopter. And that's the patient that needs the level 1 trauma center and would benefit the most from a helicopter ride to a level 1 trauma center. So in order to get them on the helicopter, that is sort of one of the areas where a drug-facilitated intervention can really make a difference. Not only does it protect their airway, it's a ticket onto the helicopter that they probably could not get on without a definitive airway from us. And that could be worth staying on scene longer for. So if we're waiting for the helicopter and we're going to do this, if it takes 10 to 15 minutes even to do, then that can get them to the level 1 trauma center hours earlier, which is where the surgeon's going to maybe able to correct their head injury. That is one of the tools available that can help with the trauma patient. Very controversial. The flip side of that is some patients seem to do worse when they're intubated by paramedics. Some patients have periods of hypoxia during the intubation attempt, and some patients develop hypoxia during the intubation attempt. Some patients get hyperventilated after. Some services have low success rates. So I don't know what the answer to that is. There's a lot of variability among local services about that. But that is one tool that could benefit trauma patients. So if the patient does not meet a trauma center criteria and they're in a lot of pain, then we can manage their pain before moving them. We do not need to rush. So if it is, one example that happens pretty frequently is a hip fracture, which is a geriatric patient. It's actually the proximal femur, but people call it the hip. And the patient falls, they break their hip, they're in a tremendous amount of pain. So they do have pain around their pelvis when you palpate it, but it's a low mechanism. It's probably a ground level fall or maybe a fall down some stairs. And if you do a head-to-toe assessment and that's the only injury you find, then we have time to manage their pain. So you can start an IV in the house. You can get their pain under control. So maybe fentanyl, maybe even ketamine, and we can move them out. And so the same with extremity fractures in kids even. Intranasal fentanyl, kids tolerate that better than having an IV started. So we can do that before moving them if it's an isolated injury and they don't meet a trauma center criteria. So the takeaway is if the patient meets a trauma center criteria, we're going to do our primary assessment, a rapid head to toe. We're going to move them to the ambulance. So vital signs should be on the way to the hospital. Starting an IV should be done on the way to the hospital or after moving to the ambulance.